And so I'm going to be talking about work that I've been pretty passionate, like Dosk said, and focused on for a while now, looking at structural racism and the multiple pathways to psychosis. And so I don't have any disclosures to report. And so I always like to start this talk with a definition of race and racism. I always say we wouldn't be talking about race if there was not racism. And so it's sort of not about individuals. To me, it's more about this system, this socially constructed stratification, but of power, right? That's really mainly based on proximity to whiteness, with individuals of African descent being the most distal category. And so I'm always struck when my doctoral students who are from abroad come here and they go, "What? I don't understand this concept of race here," and sort of trying to understand it and realize why am I perceived as white, or why am I treated this way? I'm from Jamaica, or why? And so it really just sort of highlights, in my work, just how socially constructed race is, and it depends on the history of wherever you are in terms of racism. And so one of the reasons I was sort of invited here was to talk a bit about this long history of racial differences in the prevalence of psychosis, and basically the prevalence being, what's the percentage of folks around these social racial groupings that have psychosis. And many studies have focused on those of African descent, Black folks with the highest prevalence. And so this overdiagnosis, which is what some people have referred to it, of schizophrenia in Black people. Meta-analysis that has been published showed Black individuals to be 2.4 times more likely to receive a diagnosis of schizophrenia than white individuals. And working on a meta-analysis now, hopefully to be published soon, showing similar patterns, but with a little bit more nuance. But this is based on clinical settings, mostly inpatient research, hospital settings, VA settings, and birth cohort study actually showing this increase. And even more recently in the All of Us research program that has over 300,000 folks in the system, showing again this increased odds in adjusted analyses of Black or African-American identified folks having a diagnosis of schizophrenia. And so this was 2022. So again, in clinical settings, right, particularly, we see this higher prevalence. So why am I connecting this racism and psychosis, right? And I see this being connected actually through two pathways, well, multiple pathways, really. The first, actually, historically, has been through this understanding of bias that we have in our medical systems, in our research systems, in our institutions, and how that shows up in the diagnostic practices. But more recently, I think more attention has focused on social determinants being another pathway through which structural racism can actually potentially shape the social and physical environment that we live and age within, and potentially have consequences for psychosis among different racial and ethnic minoritized groups. And so in terms of the first pathway, folks have talked about psychiatry and racism in medicine, and the idea of social control in socio-political movements. And so Jonathan Metzl wrote this book now that I think many of us have read, The Protest Psychosis, which kind of documents a timeline when schizophrenia became racialized, when schizophrenia became a Black disease, if you will, a disease that was more common among Black folks. And this happened coincidentally during the Civil Rights Movement, right? And so he and his team really documented the differences they saw over time. And so pre-1960s, pre-Civil Rights Movement, you saw folks with schizophrenia described as sort of more likely to be withdrawn, sort of docile, confused, sort of these were the kinds of terms that were kind of more likely to be associated. and were associated more with white people with schizophrenia. And then during the civil rights movement, there was this shift, right? You started to see more words like paranoid, aggressive, dangerous. And so this contrast in the way folks were described with schizophrenia coincided with an actual socio-political movement. You could say it was coincidental, but other folks kind of felt like, no, actually there is something to this. And there's a long documented history of racism in medicine that I don't need to go into. But again, this has in some way shaped the uh, higher likelihood, if you will, for peoples of African descent to get a diagnosis. And so actually this maybe is artifactual, right? And so there's a lot of work done by scholars in the field talking about the biases in that clinician diagnostic encounter, how Black folks who are depressed, just not seeing that, but we're seeing more likely to see psychosis, more likely to see the paranoia, not the depression, right? Even recently in the Rutgers Community Outpatient Clinic, there was a study that was done, Gara and colleagues, where they showed that folks, Black folks endorsed a good amount of depression, self-report, yet were more likely to be given a schizophrenia diagnosis compared to their white counterparts who endorse less depression. And so is it something happening where in the diagnostic encounter where we're missing the affective symptoms? And this was also found with Strakowski and colleagues in terms of mania and not really seeing that component of the clinical diagnostic picture. More likely to kind of jump to the schizophrenia conclusion. In terms of bias, also missing the role of historical Black trauma in the clinical presentation and how that could look in the one-on-one encounter, and dissociative kinds of symptoms connected to trauma being perceived as schizophrenia or psychosis. So that's sort of pathway one, where there's been a lot of work where, without a doubt, Black folks have been misdiagnosed, they've been overdiagnosed with schizophrenia, and there's that definitely represents some portion of the variance in the differences in the prevalence, particularly among Black populations. And this, of course, has been seen internationally also in other high-income countries like the Netherlands, the UK, et cetera. And so I think the pathway two is sort of acknowledging that there's more than one pathways to an outcome, right? And so even though there is documented misdiagnosis and overdiagnosis, could racism also be a fundamental cause of differences in the prevalence of schizophrenia or psychosis continuum through social determinants? And that's something that I've been looking at. Okay. Let me just close this chat here. Okay. And so when I talk about structural racism, I'm not talking about sort of like someone calling me the N-word, like one person here or there. It's really like actually much more connected to the institutions that we, keep us going, that we live in, these interconnected but inequitable institutions, right? When you think of housing, where people live, you think of education, where your kids go to school, likelihood of getting a job, likelihood of being caught up in the legal system, right? There's a way in which these systems, structural racism connects these systems through discrimination and inequitable practices and policies. So for example, if there's discrimination in housing, even I can't get a house in certain neighborhoods in New Jersey, right? Because of the color of my skin, right? Despite my income, or despite my going to an Ivy League school, right? There's a way in which there's discrimination in housing that's going to affect what kind of educational opportunities my kids then have, right? And so that then is going to affect what kinds of employment opportunities that they may have, right? So you can think about how, where you live, if you don't have certain employment opportunities, what kinds of things might you be doing to survive, right? What kinds of likelihood are you to be caught up in the legal system, depending on where you live? And so structural racism is not just sort of like a bad apple, if you will. It's really these policies that are connected through institutions we can't avoid, right? We can't avoid. And so this is a hypothesized model that folks in me and Els van der Ven in the Netherlands and a group of psychosis researchers really interested in trying to increase our understanding of like how the social environment might play a role in psychosis. Really thought through a model where we think about structural racism as like a fundamental cause of different levels of exposure. So I talked to you about the structural level where you could think about the neighborhood, but then that also increases your likelihood to experience discrimination, right, at the individual level. And then that then can increase stress and other kinds of potential biological mechanisms that are connected to psychosis risk. So for example, there's a large literature looking at prenatal exposures and psychosis risk. And so we see that that's absolutely the case, but that this could actually be also connected to these sort of higher order factors, macro level factors. And so this is what we actually found in sort of reviewing the literature. And so what I'm going to do for the rest of the time is to kind of show you some of the empirical evidence that might support parts of this model at the multi-level exposure level. And so one of the possible consequences of this kind of model is that there could be increased risk, at least increased risk to psychosis risk factors, right? But potentially increased risk for folks perceived, further away you are from being perceived as white, but also decreased prognosis, right? Because if you don't have access and your pathways to care are not the same, then you might not do as well, and then you'll be increased prevalence in patient population settings. So I kind of see that these are possible consequences to pathway 2, where some of the studies I showed earlier, where there were these disparities in the prevalence in patient settings, where you see it higher in Black populations in particular, that could also be connected through this pathway, could also be a consequence from this kind of pathway. And so one of the areas of psychosis sort of continuum and thinking about experiences and symptoms kind of looked at that more in the United States more recently. These are symptoms, experiences, while they may not necessarily, they do increase risk for psychosis, but in a very small portion, but they're also really considered almost like a transdiagnostic marker of morbidity because they're associated with poor prognosis among those even with anxiety and depression. And even with these kinds of psychotic experiences, things that are sort of like suspiciousness, sort of sub-threshold psychotic experiences, we still see the racial disparities in this in epidemiologic, even household general population studies. And so again, Black and Hispanic individuals in groups are showing higher prevalence than Asian and white populations. And this was in the comprehensive psychiatric epidemiology studies Cohen and Marino published. And so, when you look at this at this level, you think, well, Deidre, there's no diagnostic bias here, right? These are self-report, these are folks, and some are saying, look, these are distressing. These experiences are distressing for me. So they're meaningful, whether they are necessarily some biases in the measurement, that's a whole nother talk. But at the same time, it's still to me significant because it speaks to what people are reporting. And there's still, again, this disparity. And so what I looked at in my cohort of emerging adults with my former student now attending at Memorial Sloan Kettering, Dr. Florence Liu, we wanted to understand like what might explain some of these disparities, these racial disparities, kind of going back to that model. And so we looked at racial microaggressions and major discriminatory events. And I'm sure most of you are familiar with racial microaggressions are those subtle digs that kind of imply you don't belong or you're sort of maybe should be feared, right? But they're things that are not necessarily as major, like I'm gonna, you're not going to get a job, or, things like that, which are more major discriminatory events. And we found that, these kinds of discrimination actually did explain differences not only between Black and white emerging adults, but between Black and Latinx emerging adults, with Black being higher prevalence of these psychotic experiences. And a good portion was explained by exposure to discrimination. In another study, my colleague, Dr. Hanzo, this is a very large sample of college students, Healthy Mind study across the United States, 140 universities. 38% of Black versus 30% of white college students reported these psychotic experiences. Again, this was significant. Again, this racial disparity at the psychotic experiences level. And not only was it discrimination that mediated this, this racial difference, but food insecurity. So now we're getting to other social determinants, right, that are very much an issue. I mean, I can't tell you how big of an issue food insecurity is in colleges in a way that you would not expect. You think college, oh, that's a different sample altogether. But with college that I work at, we have a pantry, right? And so these are the two factors that really stood out as mediating this difference, racial difference in psychotic experiences, again, connected to these social determinants. Another study, just on all my wonderful colleagues, Jordan DeWilder, they did a representative sample in the United States and found, again, Black and Latinx young adults, showing higher prevalence of any psychotic experience, but they also looked at very specific types of psychotic experiences, hallucinations, delusional mood, thought control, and saw, for the most part, that there was this disparity. But they looked at a wider range of possible multi-level mediators. And the ones that really stood out, for example, was police violence exposure. And I think that's particularly unique in the United States, where there's a lot more gun violence and gun fatalities and police brutality. But that explained in adjusted analyses some of that differences between Black and Latino and white folks in the United States. But again, racial discrimination pops up, adverse childhood experiences, and educational attainment. So these were some of the mediators of that racial difference. And so one of the things that I focused on is really trying to think of what are some of the potentially protective factors or factors that are related to folks, of color getting better in particular. And this has been something that's been looked at particularly in the UK, the idea that the neighborhood and the ethnic density of the neighborhood could be protective or be something that helps folks, particularly of color. And that's basically the portion of your own group or just minoritized groups in general in your neighborhood, the level of diversity basically in your neighborhood. And so minoritized folks living in high ethnically dense neighborhoods have some protection. And folks have looked at this where the lower your neighborhood ethnic density, the higher the odds of psychosis. And this has been looked at in the UK and the Netherlands in case control studies where there's actually diagnosis of schizophrenia or psychotic disorder. And so what I wanted to do is, I'm always interested in trying sort of risk and prevention, and so we looked at this area level minoritized ethnic density across the North American prodromal longitudinal study, which is based in the United States and Canada. We looked at mainly there was a couple participants from the Canada site, but we wanted to understand the degree to which childhood ethnic density, growing up in a neighborhood and having a diverse other folks of color around you, could that actually relate to folks who are at clinical high risk getting better 2 years later or getting worse, right? And so just in the interest of time, over 24 months, folks were followed and 28% went in remission, which is what you'd love, right? 30% stayed symptomatic, 25% progressed, and 18% converted to a clinical psychotic disorder. And so what we basically found was that a higher degree of childhood minoritized ethnic density was related to a lower likelihood of staying symptomatic over that 2-year period and progressing and getting worse over that 2-year period compared to being in remission. And so to me, this was pretty interesting because this is prospective, and it's kind of like speaking to the power of like, well, what's going on in these neighborhoods that have this diversity, right? And so we looked at one of the possible explanations that we looked at in other studies in the general population, and looked at perceived discrimination again. And we saw that, the higher the childhood ethnic density, minoritized ethnic density, the higher the likelihood of remission. And 11% of that was because there was less discrimination perceived over the course of time, any lifetime discrimination. And so, neighborhoods with a plurality of ethnicities may mean no one group feels sort of isolated. Maybe there's more supports. Maybe there's a way to attenuate the stress and isolation associated with discrimination. There are more mechanisms in place, or there's more validating kinds of spaces to process when you have those microaggressions come up. And so the idea that this is something we should be looking at in adulthood only, I feel like, the idea that there's racial differences and attributions attached to these differences, that starts early, starts very early. Trust me, I have 2 little Black girls, and I can tell you that starts earlier than I would like. And so when we think of intervention and we think of like social environments, right, we could be thinking about even earlier. And so I'm going to try to make sure I stay on time, Dost. So I wanted to kind of just move into a study that I'm writing up now. I've actually did a newsletter and a webinar for, but it's Black Photo Speak, where I really wanted to highlight the voices of the Black young folks who have a first episode of psychosis, who are not at our research tables, right? And get a sense from them of what is anti-Black, like what is racism? What does that look like for you? What does that look like in your neighborhoods, and how do you get support? And so what we did was and this is a photo voice study, which is a method where folks take pictures and then they write a caption, and then they actually come to as a small group, and we did this virtually, and discuss it and talk about, what do you see? And so some of the prompts, there were 3 prompts, 3 different sessions, thinking about what role racism in your community plays in your well-being, thinking about the role it played prior to entering your current treatment program, because these are all folks in On Track New York, and what kinds of ways family and community are supporting your path towards mental well-being. And so we found that some of the themes that came out of this was this idea, like this tokenism and lack of belonging, in terms of how did it look for these young folks, hypervisibility, concerns about police, and then the chronic exposure and kind of minimizing of it. Like, oh, that's just the way it is. And so, like, I don't want to say helplessness, because that's kind of strong, but like an idea of like, this is just the way it is. But the ways that anti-Black racism really created mixed feelings about home, neighborhood, and community. And so that was really like a predominant sort of finding in terms of the themes that came from this part of the study. And so just some quotes that came out, it's important, especially like being like African-American in a Caucasian world. I felt like an outcast, it was the fact that I'm the only Black person. Sometimes I don't know what to do. I don't know, they don't know what I've been through. What do I say to them? These are their words, not mine, right? One participant talked about, being at a pretty white college, predominantly white college, and feeling like an outcast and not having a hard time sleeping. So you can imagine if you're now also having some symptoms, that having this also could really, really exacerbate that process and increase the sort of feeling of isolation. And so here's a photo that one of the participants shared, and, in terms of the prompt, how is it, showing up in your community? I mean, and I wish I had time, but like when I've done this before, it's like, what do you think of? What do you notice in this picture here? You've got these beautiful flowers, right? And then this hardcore barbed wire. Like, I dare you to go in there, right? You will get cut, right? And so she said, where I come from, I'm used to having a big police presence, like with this picture. I always feel like home, feeling sometimes like a prison cell. Other times it's just, it's like a rose that grows in concrete. So you could see the conflict there, in that internal conflict there. And it's so vivid in this picture. Again, this mixture. And so, in conclusion, racism is shaping lives, perceptions, opportunities, even when it's not explicit. And that's the point here. It's embedded in a lot of our institutions, and it has an impact, negative and positive. In terms of, well, not racism, but like in the community, we always think community is the safe space, but because of racism and other things, it's not necessarily always the case. True diversity in our treatment settings, decreasing that tokenism, because it increases hypervisibility, and hypervisibility increases paranoid ideation, which feeds the hypersense of hypervisibility. And that was something else that came out in this study that I didn't get a chance to go into the detail of, but like there was a way in which it was kind of like I'm under the spotlight, which for somebody who's already struggling with some paranoid ideation is challenging. So addressing some of these factors may increase treatment engagement overall and improve prognosis. And so really, let's address both pathways. We still have work to do in psychiatry, right? We've got our DEI work going. We have to address variance in our measurements, increase use of the cultural formulation and intake. There are things we can definitely do to reduce bias in our diagnostic practice. But let's also go upstream, right? Let's reduce these inequities in the systems and policies, and maybe we could even address discrimination in our interventions. I think that's something else that we could really, I think I've been reading more about actual empirically and validated studies that are looking at racism and racial trauma and like addressing it in our interventions, or at least bringing it up in session, or at least asking about it. So I know I'm at time. Just want to thank all the folks at On Track New York, Opal Funding, and all my wonderful, wonderful doctoral students and team members. Thanks so much. I'll stop sharing.
Thank you very much, Dr. Anglin, for this powerful presentation. There are a couple of questions. One quick one, is there a place that the photos from the study can be viewed? I think those are powerful.
Oh boy, there are many photos, and they're not housed online. Some of them are a bit more private, and so we haven't had a place where we could just put them where everyone can just go to them. So you have to go to all my talks. I'm sorry, no, I'm joking, but
perfect.
But unfortunately, no.
Okay. One other, and then we have a couple of people also on the call. But one other question is, one thing as a psychiatrist I often see is diagnosis of personality disorders to explain symptoms of mania and psychosis in people of color. The longitudinal history is overlooked or there's no effort to obtain it. Can you comment on this?
Oh, wow. Well, I guess I'm one of those people. No, I think that's really even more complex. And that's something that I haven't really, sort of looked at to the same degree. So I wish I could comment on that. Yeah.
Yeah. Interesting area to look into.
Yeah, that's definitely interesting. Mm-hmm.
And then two more questions. One is Ken. Please go ahead.
Yeah, thank you, Dr. Anglin, for your talk. It was, it was really painful to hear, but really important and necessary. So in your final slide, you showed, you mentioned some ways to ameliorate some of this discrimination and bias and racism, and I'm wondering where among them do you think is the most leverage? What's most fixable?
Yeah, I think through those institutions that I mentioned, like if people say, well, how do we dismantle racism? Well, it took centuries to sort of get here, right? And so I think at every institutional level, if everyone is doing this kind of like DEI type of work, right? Not in psychiatry, but in legal systems, they're changing policies there. They're changing policies in housing, right? They're making it so that there's less inequities. That's one level, but that's a much longer marathon, right? But at the clinician level, right? I think one time I presented this and a psychiatrist said, you know what? I'm looking back on my session with my the patient I had, and she was actually talking about not feeling like she belonged, and I didn't even really probe that. You know, he was sort of reflecting back on that session. And so if we even are all as individuals more open to and sort of not fearful of asking about that sense of belonging, and it may be not around race, it might be around other identities, but like that's an important element. And so I think that could be another area where we really focus also on the individual level. Like it can't be only one or the other. But I think the institutions also need to be addressed in terms of the inequities.
And I think we have time for one more question. Vera, please go ahead.
Yeah. Hi, Dr. Anglin. I really enjoyed the presentation. I connected a lot very personally to a lot of like what you presented in terms of like both like the stress of like being around a predominantly white institution or like operating within it as a student or as just being in a community that is not very racially diverse, and like how much stress that can put on an individual. And I do think about like the ties to like the minority stress model and sort of like other concepts of like allostatic load, like the wear and tear that takes on your body of just like experiencing constant stress from like racial discrimination as well as just like the material conditions that you live under. And I also I guess this is sort of a question that I saw also popped up in the chat, but like I'm thinking about like the capacity of institutions to better serve non-white clients, families, patients, like people in the industry. And how to overcome those challenges is I think something that I've been thinking about a lot, because I think that as an industry we're talking a lot more about DEI, and also I feel like there's these long-standing like generational pathways that have been like excluded from communities, or that have excluded communities of color for generations. And so we see a lot of people who have a lot more systemic power tend to be of those privileged identities. And I'm wondering, I guess what do you think would be some of the most significant steps that an institution can take to make sure that those disparities are being addressed? Because I think it's partly a workforce issue and it's partly like an academia issue, because like a lot of people are being lost in that. I don't like using the leaky pipeline because it sounds passive, but like there's different points of that pipeline where people are being lost because the access to the next step in the pipeline is not being made accessible. But
Right.
that makes sense.
I mean, no, I really appreciate your comments. You know, I think about when that sort of revealing, not so revealing to me, article came out where it showed, you know, why there are no, you know, very few Black folks getting R01s, you know, in that level of academia. And they identified it's the resubmit, you know, it's that resubmit because you're never going to get the first one right. It's the resubmit, boom, we fall off, right? Why? Right? Where's the mentorship, right? And so there's a lot of, like you said, holes that need to be kind of filled. And I think that in any institution, you must be in an organization. And I remember learning that early when I was at Cornell, like, because if you're just there alone, you know, you're not. So when I look at On Track New York, they have a youth organization that is no joke, and they meet and they talk, and I've presented there and just talked with them. And so I think the more there are organizations that are dedicated to filling these holes, these leaks, or if you call them, I don't know why that's kind of filling, that's kind of speaking to me, but that you can't just have one person, you know, and the leader of that can't be the one Black person or the one South Asian person or the one, you know. So I think organizations have to be dedicated to these holes. Otherwise, the system will continue as it is. Sorry, Ken, for being more like bad news, right? But it's the truth. I mean, this isn't our first revelation. But like, yeah, in psychiatry, maybe it's coming a little bit more hard, right? In different academia, it's coming a little bit more like, ooh, it's in my face a little bit more. But this isn't the first time folks go, oh, there's some inequities here, right? So it takes persistence, but we have to keep these organizations funded. We have to keep them with people running them, you know, interested in them. So that's the kind of how I see it.
Thank you so much.
Thank you very much, Deirdre. You know, another one where we could talk all day. There's so many important issues, and we really appreciate your contribution to the meeting.
Thank you so much for having me.
Thanks for joining us.